Good morning, everyone. Welcome to the 436th meeting of the Pennsylvania State University Retirees Association. My name is Chris Hurley. I'm the president-elect and also the interim program committee chair. We have a great program today and a timely topic. But before we get into that, I'd like to introduce Glenn Carter, who's the president of our association, for some comments and some updates. Glenn?
Thank you, Chris. Welcome, everybody. Looking forward to our program. I'll just take a couple of minutes to update everybody on the association. We are very healthy. We just got word on Tuesday. We currently have 1,375 total members from 836 households. That's a significant growth over the last year. We'd like to see some more, so pass the word. As you recall, last spring, we finished our strategic planning, which we worked on for about a year and a half. And of course, we've had struggled with having to do everything virtual through Zoom this spring. So we have not made as much progress, perhaps, as implementing some of our goals as we'd like. We have made some significant progress. If you recall, we got a new board, new goals and constitution and bylaws, a policy manual, and a procedures manual implemented, which is always all behind the scenes things. But you notice that the communications have improved and a number of other things have happened as well. I just want to touch on a couple of things before we move on. One is that we continue to need help. We'd love to have some volunteers for some of our committees. They includes the program committee, the communications committee. We're looking for perhaps some people with IT skills there. And of course, publicity and membership could also use some volunteers. So you, or if you recommend somebody, we'd love to hear from you. The second point I want to touch on is the retiree benefits program. We do have some funds to support people who are really in financial help. If you are or know someone, have them get a hold of Iris Flynn. It'd be all held and confidential. See if we can help some people who are really hurting. And we look forward to seeing you in live this summer, spring. Hopefully we'll have fall at least. And I'll just say, stay safe, and I'll turn it back to Chris.
Thank you, Glenn. Before we get started, I wanted to mention a couple of housekeeping items. If you would like to ask a question to our presenter today, what you'll need to do is to go into your screen, either on the bottom of your screen or the top of your screen, depending upon what type of device you're watching today. You'll click on the Q&A or question button, and then you can type in a question. If you have an iPad, for an example, you might have to tap your screen in order to get that menu that comes up so that you can tap on the Q&A button. When you ask a question, it'll be put into a queue. And then after the presentation, our presenter will be able to answer as many questions as possible. Also like to remind those of you that if you're not speaking, please put your system in mute. Also a reminder that this meeting will be recorded. We will be posting it on the association website. So if you want to go back and review it or tell someone else about it that might find the information helpful, you can mention that to them. So without further ado, as they say, I'm going to introduce to you Alan Cameron. Alan is our immediate past president, and he will introduce today's presenter. Alan?
Thanks, Chris. My own introduction to our speaker was about 30 years ago. We used to see him drive up and park across the street from us over in McCormick Avenue to pick up the young lady who lived there. And Tracy is now his wife and a very well-known local optometrist. After receiving his Bachelor of Science degree at Penn State, Rod received his Doctor of Medicine degree from Jefferson Medical College in 1990, followed by a residence in internal medicine at the University of Virginia. And that led to his board certification in internal medicine. In 1993, Rod joined a practice in Oil City, Pennsylvania, and simultaneously served as medical director for a nursing home in the area. He relocated to State College in 2005, at that time becoming a partner in Nittany Valley Medical Associates and medical director at Foxdale an active staff physician at Health South Nittany Valley Rehab, and a consulting staff physician at Mount Nittany Medical Center. From 2013 to 2018, he added service as medical director for 3 other senior medical facilities. He was certified as a medical director, board certified in 2016. And in 2018, he moved from those additional 3 to now serving as the medical director for Harmony at State College. Rod has worked very closely with the Foxdale administrative team proactively to initiate policies and procedures to protect the residents of the Foxdale community before almost anybody else in Pennsylvania took coronavirus very seriously. You may recall that our March 2020 meeting was canceled. We had planned to meet at Foxdale. It was canceled on less than 24 hours notice because this was part of the preventive, proactive initiatives that Rod, in connection with our administrative team here, took to protect the Foxdale residents. Throughout this pandemic, Rod has periodically educated and updated the community, and I'm pleased that he'll do the same for our broader retiree community this morning. It's my pleasure to introduce my primary care physician, Dr. Rodney Sepich. Rod, it's all yours.
Thanks, Alan. Let me see if I can get the share screen working here. We've all become Zoom literate, I guess, over time. Let's see here. All right, is the share screen working okay? Can you hear me?
Looks great, Rod.
Yes, it is. It looks great.
All right, just wanted to make sure it was working. Well, as Alan said, certainly 2020 has been a very challenging year. Trying to keep what essentially is a relative of a cold virus from coming into a community, where people live closely and that we constantly have workers coming in and out is certainly been quite a challenge. It's just really difficult. So 2020 was pretty depressing, but I want to try to focus on, as we go through this, we'll talk a little bit about 2020 and some of the issues there, but I'm hoping to focus toward the end of this really on where things are going, and I think we certainly have some reason to be optimistic. One of the ways I think about this whole storm of COVID, so to speak, is thinking about a hurricane coming through, and I keep moving where this arrow is. I think that initial episode of COVID coming into our country certainly was like the beginning of a hurricane, and with our March shutdown certainly affected everybody, not just with the virus, but economically we've certainly had a challenge in 2020. The summer was kind of like being in that eye of the storm, and since we hit fall and we started getting more spread in fall and the winter, we're certainly in the back part of that hurricane, and I hope to God we're going to get out of it. So what we're going to focus on is just updating a little bit of where we are with the infection and death rates. Mention a few things about the conditions for spread, talk a little bit about the infection and how we treat it these days and things we do to mitigate the pandemic. So looking at the national statistics and the number of cases, you certainly can see that there was a little surge in the spring, but then the summer gave us a little surge compared to what we've experienced in the fall. This certainly has been the worst part of the pandemic. If you follow a timeline of the influenza pandemic back in 1918, there certainly are a lot of similarities to what we've seen here. This next part is just looking at the number of cases versus the number of deaths. And what I think is interesting about this is you'll notice that the death rate at the beginning of this pandemic was certainly much higher in relationship to the number of cases we were seeing. I think that probably has a number of reasons for it. I think part of it is we've learned over time, and I actually should probably change this first one, is that we're focusing protection on people over 60. We've certainly have improved some of the treatments related to the COVID infection. As some of the younger population became infected, they don't have such bad outcomes. So probably a combination of all this would be the theory about why our death rate is not quite so bad. What I'm going to go through in these next few slides is just an interesting website to kind of follow a lot of what's happening with the pandemic is this COVID tracking project. And they have a lot of great charts to just give some understanding of how we're handling this through the whole country as well as locally. You'll notice that these next few slides, we're just going to look at how this affected the country through different time periods. Certainly this came in the West Coast, and we know about in Washington State, we first had a pandemic affect a nursing home out there that showed us that when you get this infection in a nursing home, you're going to have a death rate that's about a third of the residents. So it's certainly very lethal in that environment. And then we also had certainly an outbreak in the Northeast as well. Interestingly, these appeared to be two different viruses. This Northeast strain came from Italy and had a mutation that made it more infective than what the West Coast strain appeared to be. As we moved through the summer, we saw a lot of outbreak in the South. And as we talk a little bit about conditions for spread, one of the things to think about is in the South, in some ways, it's like in the South during the summer, in some ways like our winter up north, in that people go inside and are in air conditioning with lower humidity. And not only being inside, but having that lower humidity tends to allow spread more easily. As we came into August, we had thought that the Midwest was spared in this, but certainly not. The Midwest got worse, and then the infections start to come back east. And as we get into September, October, and November, you just see the whole country blow up as we got into the fall. Actually, this is early January. Or middle of January. This is about where we were peaking, what I hope will end up being the peak of this whole pandemic, and certainly all of the different states in our country were having quite an outbreak. At least here in central Pennsylvania, you can see Pennsylvania had pretty high numbers, and this has certainly been our peak here in December and January. Now, this is only 4 days or 6 days apart. This is January 14th. This is January 20th. And interestingly, we're already seeing some decline in most states. So that, I think, is very encouraging. As far as Pennsylvania itself, since a lot of folks are here in central Pennsylvania, again, it's very encouraging that our daily cases are really starting to decline, as well as seeing some decline of those folks who are hospitalized. It usually takes about 2 weeks after this hospitalization number, somewhere between 2 and 3 weeks, to see a decline in the death rate. I think we're just starting to see that now. So I think over the next few weeks, the death rate in our state will start coming down. So in thinking about Pennsylvania in particular, I think there's one interesting part to this. Much of Pennsylvania outside the eastern part of the state was really relatively spared in that first wave. And one of the interesting thing in talking to the labs around here is when you looked at the viral genome here in central Pennsylvania, it appeared that the virus was more similar to the virus from the West Coast, even though we're obviously much closer to New York. And then the New York virus was actually a little more infective. And what I think that tells me is that I think there was some certainly positive effect to the lockdown we had in March. I know there's a lot of debate about the lockdown in March, but from my own personal perspective, I think that was necessary and helpful because we didn't have as much testing available at that time. We certainly were not prepared with enough personal protective equipment, and not seeing that virus spread from New York and Northeast Pennsylvania over to here, I think was partly due to that lockdown. So it was very helpful. Even though we're talking about the health things, it's important to remember, I think, the economic impact of this whole thing, and some of the Google statistics on where people are located helps understand some of the effects of this pandemic. And I always like to point out that the economic impacts have a lot of effect on our healthcare as well. We certainly have heard about increases in domestic violence, alcohol use, suicides, depression, and the isolation that we see that has happened with this pandemic certainly is something we need to think about going forward, because it certainly is having an effect on our health. And these statistics are not surprising that retail type things, as well as gyms and groceries and pharmacies, are seeing less foot traffic. Public transportation is obviously seeing less traffic. The place where we're seeing increased traffic are the homes and the parks, and that's not surprising either. Workplaces are still down about 15% compared to normal, and hopefully as we get towards summer, we'll start seeing some of that come back. So just moving on to talk a little bit about the ideal conditions for spread. Some of the early data was really interesting, that temperatures between 41 and 52 and Fahrenheit, and relatively low humidity, 40 to 75, seem to be the situation where COVID spread the easiest. And people who live in hot climates are not not spared from this as we get in air conditioning and the humidity is lower. And those meat packing plants, we certainly have seen are ideal conditions with lower temperatures and lower humidity for the spread of this virus. I think this is a really interesting, we've talked a lot about this pandemic being similar to the 1918 pandemic. One big difference is that if you look at the mortality rates, especially below around age 60, the COVID mortality rates are nowhere near what the death rates from that 1918 influenza pandemic was. One of the things that really stands out to me is about 1 out of every 100 people around age 30, 25 to 34 there, who got influenza in the 1918 pandemic died from this. And I just can't imagine seeing all the, so many of the young folks die, and certainly the infant mortality rate was very high. The other important thing to get out of this is that it helped us understand the population we needed to focus protection on. Clearly, people 60 and up, I think, need to be even more aware than the average population about trying to prevent getting this virus. And as we'll talk about, it's not just a death issue, part of the issue here as well is thinking about what are the potential long-term effects of COVID. So this is just kind of some of the same information, some of the case fatality rates by age, and certainly it goes up over age 80. I don't have over age 90 in here, but I did find another source where the case fatality rate over age 90 is in the 40 to 45% range. It's actually much higher than what we're showing here on 80 and up. This is a nice summary of how the COVID virus infection proceeds through the body. The first phase is more related to the virus replicating and our response to that. And a lot of times people will have basically more flu-like symptoms that you think of classically when people get the flu in the winter, with some cough and headache, muscle aches, and just feeling extremely tired. As that virus is replicating, our immune system is starting to ramp up. And what is really devastating about COVID infection is this inflammatory response that we end up getting from COVID. So a lot of folks get through this viral phase, and although they may have cough and some difficulty with some wheezing or with even their oxygen levels, where we really suddenly get into trouble is you get somewhere between, I would say 7 to 14 days. A lot of times I'll start seeing folks get into this inflammatory phase where their lungs really start to sound fibrotic. They have these really fine crackles in them, and their oxygen levels may be starting to go down. And then you'll see that there's this third phase in here called the hyperinflammatory phase. And it almost always occurs in what I'm seeing in majority of people between about day 16, 17, and day 21 to 22. At that point, it's not uncommon if you hear these stories about somebody seeming to do fairly well, and then an hour later, their oxygen is suddenly dropped and they're having a really hard time. They're usually going into this hyperinflammatory phase, and it is very difficult to get people through that. So I'm talking about this occurring 3 weeks after the infection. So it tells you that really the other amazing thing about this virus is just how long it affects someone and how sick it makes them for such a long period of time. I really, in my clinical experience, don't have anything that compares with it. So as I mentioned, is death the only concern about COVID, or are there other long-term effects? Or what about persistent infection or reinfection? This is a nice summary of the folks who end up in the hospital are about 5% of people. That's what we would describe as severe to critical symptoms. Really, the folks who are hospitalized or folks who are dropping their oxygen level is primarily the reason. Really, what to take from this is that you only get full recovery in about half of folks, and about half of folks appear to be stuck with the scarring that you get in the lungs. And there's really some long-term effects from this, resulting in people being stuck on oxygen or with chronic shortness of breath, even if they recover to leave the hospital. The other organs that seem to have some long-term effects is these are MRIs of the brain. As you look through some of the brain structures, you'll see some areas that have increased white areas through there. And those are areas that essentially are tiny little strokes that are destroying brain tissue. And there's a lot of folks who, as they get through their COVID infection, end up with long-term brain injury. sometimes we call this COVID brain, and you don't get complete recovery from this. Certainly in the hospitalized folks, it's not uncommon to see the kidneys shut down. One thing I'll point out is that all these different organs that we're talking about, whether it be the lungs or even up into brain tissue, your GI tract or down in the kidneys, all of these organ systems have these ACE2 receptors that you hear about COVID attacking and attaching to with the spike protein. And kidney injury is certainly part of this, and some people get liver injury as well. Early on, we saw some pictures and folks talking about some folks seem to be recovering, and then the next thing you know, they were falling over dead. And what was probably happening is COVID actually causes some inflammation in the heart in at least half of the folks who end up in the hospital. And it's very common that when you look at them with an echocardiogram, that the heart muscle is weakened. And so as the heart muscle gets weakened and they get a cardiomyopathy, you can be at risk of sudden death from that as well. So hospitalized folks certainly have, it's very common to get heart side effects. The other thing, this was from a July study, but I just saw one recently that pretty much had the same results in this one, it was 87%, and I think in the recent study I saw it was 90% of folks who were sick enough to get hospitalized continue to have symptoms of COVID a couple of months later. At least one or two of those symptoms stay. The most common ones to be stuck with include fatigue, shortness of breath, joint pains, chest pains, and cough. And some people are stuck with that loss of smell, which makes their appetite poor. One of the things I've noticed this wasn't at Foxdale, but another place that I worked, a lot of the staff ended up getting infected with the COVID virus. It was amazing. Almost everyone would tell me they lost 5 or 10 pounds with this infection. So even in relatively young folks, it's a very wicked infection. Some of the things we obviously have been encouraging to help with the mitigation of the pandemic. I spend a little time talking about masks just because I personally think it's something that is helpful, and we have some data that suggests that it is helpful, even though others will argue that there is no such data. I mean, the idea behind masks is that if you're speaking or coughing, you're putting out respiratory droplets, and we know that COVID-19 is spread by those respiratory droplets. So if you wear a mask properly, it should help decrease the spread to other people. And there's some other reasons we like to use masks, but we'll get to that. Interestingly, I agree that there's data that in the mass population, you certainly can, it's hard to show as much benefit to the mask. I think a lot of that is because of improper use of the mask, pulling masks down to talk to people, pulling masks down to rub their nose, not washing the mask, constantly touching the mask with the hands. So there's a lot of things that folks do that I think decreases the effectiveness of wearing a mask. Interestingly, there was some data that does suggest that masks are helpful. Mask mandates in states appeared to lead to a slowdown in the rate of COVID that became more apparent with time. When you looked at coronavirus deaths across a lot of different countries where the cultural norms favored mask wearing, there tended to be less death rate. And there's a couple of interesting case studies where people had the disease, and with wearing a mask, you can show that at least the people around them didn't get infected. One example here is a man who flew from China to Toronto, tested positive on his arrival and had been coughing during the whole flight, but he was wearing a mask. And as it turned out, over the next 2 weeks, all 25 people that sat close to him remained negative for the virus. And I know this one was well publicized, but there was a couple of hairdressers who were COVID positive and actually were symptomatic, but they, as well as the customers, wore masks, and all of their 139 customers remained negative for this virus. And then we've heard about the USS Theodore Roosevelt and the bad outbreak that they had, but the folks who were good about wearing their masks on board had a lot less risk of ending up with the infection. And just some other examples that were similar to that guy flying from China to Toronto, when they worked on studying infected passengers on flights that were longer than 10 hours, they really were able to show that there was not the development of COVID in other passengers and crew if masks were worn. And this was just a study that was looking at the impact of states that gave a mask mandate. Sorry, my lights went out here. So it appeared that when the mandate went into effect, the rate of infections dropped pretty significantly. So that was just another thing in favor of wearing masks. The idea behind masks is they're not only protecting you from others, but it's protecting you from yourself, trying to keep you from putting your hands in your face holes. And another concept that I think is important is, although this I don't believe has been proven yet for COVID, we know in most viral infections that the amount of virus that you get infected with initially, if it's a lower amount, you tend not to have as severe of a disease, probably because you're giving your immune system time to react. So the mask can certainly have other things that help you. The other two things we've talked about in society is social distancing and hand hygiene, and I would still continue to encourage that. So I wanted to move on to just hopefully I have a little bit of time left. Some of the positive things that I think are coming or we're currently getting into effect. Certainly a lot of folks have heard about the mRNA vaccines, and we can talk about them more if you want, but just in general, the studies that were done essentially show they're 95% effective. One of the things I'll point out that I think is important to understand, most of the folks that I'm talking to here at Foxdale are certainly willing to take the vaccine, and I think that reflects the education. But when I go across the mountain to more rural Pennsylvania, there's a lot of folks that have a lot of concerns about the vaccine. And I won't get into all of their concerns. One concern is that how quickly the vaccine was developed. And one of the things that a lot of folks don't understand is the technology in being able to study genetics is just so much better and allows the study of these things so much more quickly, that a lot of the quickness of developing this vaccine is really a tribute to our ability to understand genetics more so than anything being rushed. The vaccines were really studied, other than the long-term effects, the vaccines were really studied in a similar fashion that we have done for all the other vaccines that have been out. So I'm really confident, at least in the short term, safety and effectiveness of the vaccine. Can't comment on the long term, but just understanding how mRNA vaccines work, and we're essentially teaching our body to produce the vaccine itself. I really am confident that this is going to be a worthwhile vaccine and very safe. Another source of hope that is finally starting to be available. In November, there was some approval of monoclonal antibodies to be given. And what we found is that if we give monoclonal antibodies really early in the disease, it appears to make a difference. The two that are out there, there's one from Eli Lilly, this bamlanivimab, that actually is finally available for us. And I've given this actually in 2 different facilities now. And I swear it makes a difference if you get this virus early. In the early study of this monoclonal antibody, there was about what they really showed a difference in was the amount of people who were hospitalized, which, as we talked about earlier, is likely correlates with people who are dropping their oxygen. So in the treatment group, 1.6% were hospitalized. In the non-treatment group, 6.3% were, or in the placebo group, 6.3% were hospitalized. So this is an emergency use authorization, FDA approval, which means that it's not considered a standard of care, but it's finally become available and we can use it in the skilled nursing facility, especially. I think it's an important place to give this a try. A lot of folks are more familiar with the Remeron version that has 2 different monoclonal antibodies in it. This was the one that President Trump had received, and it similarly had good results if you give it early in the disease. If someone is already dropping their oxygen level, you should not give these antibodies. There's actually some suggestion that at that point, you don't do as well. Remdesivir has been given in the hospital. A lot of folks have heard that name. There's really only a small group of patients it's been shown to be helpful for. It's not helpful as far as we know early in the disease. It's helpful for people who are starting to drop their oxygen, but if they drop it enough that they need to be ventilated or on higher flow oxygen, it doesn't appear to be effective. So if remdesivir is helpful, it's probably only for a very select group of patients. Out of Britain, there came studies that showed that steroids had some benefit. These appear to be most beneficial in those folks who are in the intensive care unit. And if you think back to where we were talking about the inflammatory phase of this disease, that hyperinflammation that you're seeing later in the disease are the folks who are in the intensive care unit. So in some ways, it makes a lot of sense that the steroids may be helpful. If you give steroids too early in the disease, it actually has a worse outcome, which kind of makes sense because you're decreasing your body's immune system ability to control the viral replication. So some of my conclusions, the initial shutdown, I think, was effective at helping keep our hospitals open and allowed us to ramp up our testing capabilities. Death rates are declining, but still significant for those folks who are over 60. We have ways to mitigate the viral replication, meaning the monoclonal antibodies. And then we try to use the steroids. And another thing I didn't really get into, but in folks that are hospitalized or more sick with this virus, we use anticoagulants to try to keep people from getting blood clots, which is a really big issue with COVID infection. We need a consistent message from leadership to wear masks and continue social distancing and pay close attention to hand hygiene. Most parts of society can continue their business and social activities if they focus on those modifications. And I think it's important that we focus on some of those economic activities as well, because they have their own problems and health issues. Many folks infected with COVID-19 will have long-lasting organ damage, and vaccines, though helpful, will not change our need to focus on protection for the folks over 60. In other words, where I think this is going is I think we're still going to have sporadic cases of COVID-19. So given how lethal it is for people over 60, I think that this is not going away just because we have a vaccine. That's the end of that part. I think we have some question part here. Let's see.
Rod, are you able to see the questions?
Yes, I'm pulling them up here. Can you still hear me?
Yes, we
Yeah.
can.
Okay. Let's see. Do all who get infected go through these 3 phases? See, many stop after phase 1. That's a great question, and I think the comment here that do you go through? Does everybody that gets the virus go through all 3 phases? And I don't think they do. I think if you get a good immune response at the beginning that controls the virus, we don't see that inflammatory phase that gets out of control and causes other issues. I mentioned the clotting, and that's a big one. As the inflammation gets out of control, you can start getting so much clotting that you use up your clotting factors and actually then have problems with bleeding. That you may have heard of something called disseminated intravascular coagulation, or DIC, as a complication of this disease, and that certainly is a problem when that hyperinflammation gets going. What are your thoughts on wearing 2 masks? And I'm not quite sure I understand. I guess the idea might be so that if you touch the outer mask, you're not touching the inner mask. I think being cognizant of what you're doing with your hands in relationship to your masks and keeping your masks clean are important. And also, your masks are not as effective over time if you don't replace them. What are your thoughts on N95 masks? They do allow less virus in from the outside, and they are more effective than, say, a plain surgical mask. And there definitely are studies that back that up. So the N95 mask is more effective at keeping outside viruses from coming in. So it doesn't mean that they're perfect. So if you still could get a virus in, but I think that again goes to the viral load issue, that if you get less of a viral load, you're probably less likely to get a more severe infection. What are statistical rates for infection or death among professionals of color compared to similar demographics for whites? We know it's higher for non-professionals of color compared to European Americans. I've not seen specific data to answer that question, so I'm not totally sure. We know that death rates are higher, and I think this probably goes back to those ACE2 receptors. We mentioned that ACE2 receptors are involved in how COVID gets into the body, and that may be a factor why we see higher death rates in persons of color. Will a vaccinated person over 60 still be at risk? I kind of was trying to allude to that at the end, and I would say yes. Again, the vaccine's not 100% effective. And so if you do get infected, we obviously don't have the data to understand, will that mean that your infection will be less lethal? Are there some people who it will still be lethal in? We don't know yet. So if I'm over 60 and I get the vaccine, I would still be very careful and I would still wear my mask and try to not get this virus. So there's things there that are certainly going positive, but you still want to be very careful because until we have better data, you don't want to get this infection. If one obtained the vaccine, 2 doses and above 60, would he be protected from COVID-19? Maybe. There's a real positive answer. I'm confused by the last conclusion concerning the vaccines and the continuing danger over 60. So it seems like that I hope I've explained that it may mitigate the infection, but we still have not proven that it will cut the death rate. So until we do, I would be very careful. Will you test positive after having the vaccination? That's a great question. The answer is no. The tests that we're doing are looking for proteins that are not the spike protein, that are very specific to the COVID-19. So the vaccination is going to have no effect upon the testing that's being done. Have studies shown how effective the vaccine will be if the second dose is delayed due to supply limits? Not that I'm aware of, but from past experience with other vaccines, we recommend you get the second dose even if it has been delayed, and it, in theory, it'll still be effective. What can you tell us about the availability of the vaccine for people over 65 in this area? I'm assuming that means State College. Certainly there's been issues with rollout of the vaccine. So this kind of gets back to the idea that the United States does not have a national health service. And there's no doubt that when you have a national health service where everything is coordinated from top to bottom, it's probably easier to coordinate the vaccine. Public health is in our country is still mostly administered through the state. So the State Department of Health is the one that is not only controlling the distribution of the vaccine, but they also are responsible for the contact tracing and coming up with the rules for nursing homes and things like that. And in Pennsylvania, certainly, I don't know about other states, but in Pennsylvania, it certainly has been a struggle for the Department of Health. I think we're going to see people over vaccine have availability soon at places like CVS and Walgreens that have the contract in the state of Pennsylvania, probably within the next 2 to 4 weeks. I don't know that for sure. I'm just speculating. Can you give us an update on vaccine availability, Center County? So that's a similar question. New vaccine recommendations put over 60 people with underlying conditions in group 1A. If smoking is considered an underlying condition, how is it verified that a person is a smoker? I suspect they just ask them. If you truly were going to, there is a blood test you can do to tell if someone's a smoker or not, but I don't think we're going to be doing that before giving the vaccine. Describe the need for the second shot of the vaccine. That's a great question. You really do only get about 50% of the immunity with the first shot. The second shot really revs up the immune system. One of the things I'm telling my folks here is that it's going to take about 8 weeks after the first shot. So assuming you get the first shot and the second shot comes at 3 to 4 weeks, it's going to take a total of about 8 weeks until the vaccine's fully effective. But don't stop wearing your mask. Is there a way to test one's mask effectiveness before going out? Not that I know of. But I would replace the mask because they as you use them, they get clogged up. And of course they get dirty, so you need to replace them once in a while. Are patients on an ACE inhibitor for hypertension less likely to get a severe viral infection? No. And probably the reason is because people who are on an ACE inhibitor for hypertension and it's effective, those folks have a lot of those ACE2 receptors and may actually be more susceptible to the infection. It is not recommended to stop the ACE inhibitor unless you're seeing problems like kidney dysfunction that you have to stop it. In other words, when they looked at folks who had their ACE inhibitors stopped with the infection versus those not, there really was no difference in outcome. Are there any data on how long the vaccine is effective? And the answer is no, because it's too short term yet to figure that out. So we don't know yet if there's going to need to be a booster. Probably similar to the Shingrix vaccine that you may have gotten for shingles, we don't yet know if we'll have to boost that or not. Please clarify whether Penn State retirees are part of Penn State Health. I have no idea what that means. Are there recommendations in dealing with any side effects from the vaccine? The only thing I would recommend, so the vaccine side effects are mainly local. A lot of folks are not even having as much reaction to the vaccine as they do with the flu shot. But just with the flu shot, if you take some Tylenol around the time you're getting the vaccine, I think you're probably going to be less likely to have some of the side effects, the muscle aches and or the fever. And I don't think it'll affect the effectiveness. If one tests positive for COVID, how does that affect when you should get the vaccine? Get it when you're over the illness, when you're not having fevers, when you're not sick. You still should get the vaccine. It's recommended that even if you've tested positive for COVID, that you get the vaccine. So it doesn't preclude getting it, but I wouldn't get it while I'm acutely ill because you'll probably have a better response and a better long-term effect if you don't get it while you're sick. Any thoughts about the J&J vaccine, a possible signal shot vaccine that uses the Ebola vaccine footprint? There's still not quite enough data out. What we're probably going to see is well, not only J&J, but we still may see some other vaccines approved. And at some point, we're probably going to have head-to-head studies to understand which vaccine is best and recommended. In this early phase, the efforts were mainly just to get the vaccines out and approved and at least shown to be effective. So I don't know if one's going to be better than the other yet. I'm actually very encouraged about the mRNA vaccine from the standpoint of the way I think of it is it's much more targeted. I actually think we may see less. It wouldn't surprise me to see influenza vaccine be recreated to be an mRNA vaccine. We'll see how that goes with time, but I think we may end up seeing less side effects if that's the case, just because there may be more focused. You're focusing more on specific proteins rather than giving a whole attenuated virus that has a lot of different proteins in it for your immune system to react to. And that's all I have.
Okay, well, thank you, Dr. Sepich. That was a really informative presentation. I hope that it was helpful for those folks that were listening out there. I do want to remind you that this presentation is being recorded, and we hope to put it on our website. So if you want to tell people about it or want to see it again, be watching the Penn State University Retirees Association website, and that'll be coming on there soon. One of the things that I wanted to just mention, we're of course always looking for members. If you know anyone that is retired from Penn State and is not a member of the association, we certainly would encourage you to ask them to join. They can get an application form on our website. We also are looking for volunteers of those that are members. We have several committees. One of them, of course, is the program committee, and we would be happy to have some assistance and bringing quality programs like we had today. Of course, we're looking forward to the day when we can all get together again. And when that happens, we certainly hope to have some additional activities and programs to enhance the reason that you should be a member. I also would like to say to everybody that we appreciate any feedback that you may have to the club, to the association, and please get on the website. You can also contact us through the website for any suggestions or recommendations that you have. Well, at this point, I'd like to again thank Dr. Sepich. I was going to reach out to see if there's anyone on our panel that has anything for the good of the order. Okay, hearing none, we'll close the 436th meeting of the Penn State University Retirees Association. Hope everyone stays safe and stay healthy. And